Okay. I think we are live now. So if all of you can see me, I'll be keeping an eye on the chat box also. Hi everyone, this is Dr. Sandeep Sharma here. A very good evening to all the students who have joined it here. Whether you are a FMG aspirant, whether you are a NEET PG aspirant, or you are a INICET aspirant, this session, next 35 to 40 minutes, I am going to go with a breakneck speed. But trust me, if you are targeting and you want to have a good revision of image-based questions or similar images which have been asked and likely to be asked, we are going to cover a lot of ground here. No concepts I will tell you, but small hints I will tell you what to look out for in the exam if you get a question. That is what we are going to start with, right? And it is my humble request that all of you who are listening to it, please attend it live. Once it goes there in a recorded format on the YouTube after the live session ends, please save it. Please save it because I have handpicked and selected a lot of images. And if you correlate with the last 5-year papers of your NEET PG, FMG, INICET exam, you will find about 70% of all images I'm going to take are actual images. 30% are the trending images. And yes, I have included Moya syndrome also. Yes, some of you asked me about it. So thank you so much. And just a minute, please. Let me just turn on the screen now. Yes, it is visible now. So I'm Dr. Sandeep Sharma. I'm a pediatric faculty at DocTutorials for FMG, NEET PG, and INICET. And let us start with the session. So because I'm writing and also I'm, showing the image and pointing out keywords, and we have only 30 minutes to go. So I will not be answering the questions in live chat. Yes, in between, I will be taking a break, having a look. But in case your query gets missed, I am going to apologize beforehand. You all have my numbers. Most of you are connected through social media also. I will try that I answer all the queries later as well as in the comment section once the recorded video goes up, right? So all of you are, time is critical. Exams are coming. Winter is here. So let us start with the exams. So first of all, look at this scenario. This is the first image. Yes, Devendra, this video will be available till NEET. So look at this first image. They will say a neonatal reflex is being checked here. What is the likely neonatal reflex? So what is the likely neonatal reflex here? If you get an image like this, can you please tell what is the likely reflex here? Absolutely right. Absolutely right. The answer here, the likely image here, the likely reflex being checked here is Morrow's reflex. Morrow's reflex is being checked. Whenever you have a photograph of a child being held or lying on a cot and the child's neck is like this and there are extended arms of the child and open fingers, remember that it is a marker of Morrow's reflex. Morrow's reflex, key points to remember. Morrow's reflex appears at what age? It appears at, just a minute, I will make my pen also bigger, font bigger. So Morrow's reflex appears at about 36 to 37 weeks. So it is present at birth in most normal children. There are two types of Morrow. One is an incomplete Morrow, which usually appears around 32 weeks. But it will not be the complete Morrow reflex that we know. So agar पूछें कि incomplete Morrow comes at what age? Incomplete Morrow or immature Morrow comes around 32 to 33 weeks. But the complete Morrow, the actual Morrow, all the reflexes being present, all the components present, is appearing at 36 to 37 weeks. So it will be present in every normal child at birth. And what is the time around which it disappears? Normally, Morrow disappears between 3 to 6 months. So 3 to 6 months of postnatal age, it will disappear. And if it fails to disappear beyond 6 months of age, we should always suspect frontal lobe damage. Frontal lobe damage. Remember the key concept, frontal lobe damage. अब इसमें key concept क्या याद रखना है? Remember, there is a saying people say, हर adult में एक बच्चा छुपा है. There is a child inside every adult. I disagree. I would say there is a Morrow reflex hidden in every adult. Yes, you would be surprised to know that right now also Morrow's reflex is present in you and me, but it is always kept inhibited by frontal lobe. Frontal lobe is inhibitory in nature, and as age increases beyond 6 months of age, you see that the frontal lobe takes over and the primitive reflexes like Morrow's reflex tend to disappear. So hypothetically speaking, in case if there is a child who's having persistence of Morrow's reflex beyond 6 months, what should you suspect? Frontal lobe damage should be suspected, right? Pehla point. Second point to understand, can Morrow's reflex appear in an adult? You will not find in the books, but yes, Morrow's reflex can theoretically appear if there is severe bilateral damage to frontal lobe. Suppose there is a patient with road traffic accident and there is life is saved, but the person has extensive damage to frontal lobe bilaterally, Morrow's reflex has been shown to occur. So remember, asymmetric, abnormal persistence of Morrow's reflex indicates what? Frontal lobe damage. It is a past INICET question when it used to be called as AIMS entrance exam question. Also, there is another MCQ on which questions are asked. What is asymmetric Morrow's reflex? Asymmetric means एक तरफ होगा, एक तरफ नहीं होगा. Asymmetric Morrow's reflex is seen in 4 conditions. So one half of the body child will be having Morrow's reflex, other half of the body it will not be having. Asymmetric will occur typically in Erb's palsy. The typical C5, C6 injury, you will find it. It will also be seen in fracture of the clavicle bone. I hope you know that clavicle is the most common bone to be fractured during childbirth. It will also be seen in fracture of the humerus, and it can also be seen in shoulder dislocation. So dislocation of the shoulder can also produce asymmetric Morrow's reflex. I will be writing only the key points, but whatever things I'm saying, those points are also important. And that is why I said that a second listening to this video will be more beneficial to you, right? So it's a bolus dose which we are giving, but maintenance dose will be there when you listen to this video again. So make it a point, and not just my video, but all the other, this IBQ series which we are having at DocTutorials. Trust me, all of us have given a lot of our mind space and our efforts into it so that you get the finest quality in 35 to 40 minutes. So first thing, what is the reflex which is being checked? This is Morrow's reflex which is being checked, right? Let us move to the second reflex. There is a reflex which is being checked as shown in the image. What is the likely diagnosis in this child? What is the reflex which is being checked? Now, how to identify whenever there is a child, suppose I'm a child, I'm a newborn, and you turn my head in a supine position to one side, there will be extension of limbs occurring on the same side and flexion of limbs will occur on the opposite side. As you can see, jis taraf head mudega, there will be extension on the same side. So you can see extension here and you can see flexion. So jis taraf ko head muda, there will be extension on the same side. This is a child who's having what kind of reflex? Remember, it is called as ATNR. ATNR. ATNR stands for asymmetric tonic neck reflex. Asymmetric tonic neck reflex. This similar image has already been asked in an old paper of NEET PG. NEET PG 2016. It was held in multiple sessions for some reasons at that time. And at that time, one of the session, this image was kept in the exam. So all they had asked is, what is the normal time of disappearance of this, normal time of appearance of this reflex? ATNR appears in most patients before birth. It appears somewhere around 36 weeks of age. Some books say 35, some say 37. The key crux here is it always appears before birth. So every normal term baby, it is present at birth. Normal time of disappearance of asymmetric tonic neck reflex is somewhere around 3 to 4 months. I hope you know that there is a milestone called as turning over in bed, curvet lena. Turning over as a milestone begins around 5 months of age. And only when ATNR goes away, then the child is able to do turnover in bed. देखो ATNR nature ने क्यों create किया है? Why has nature created ATNR reflex? It has been created so that a child first 3 months of age does not turn over and fall from the bed. So if the reflexes are present, they are present for a reason. Normal time of disappearance is 3 months. What is abnormal persistence? What is abnormal persistence? Abnormal persistence is if doesn't disappear. If it doesn't disappear by 5 to 6 months. तो दोनों में फर्क है. If they say normally most patients में कब disappear होता है? Standard textbooks, pediatric neurology textbooks say 90% patients में 3 to 4 months में होता है. Another 8 to 9% patients में 5 to 6 months में हो जाता है. तो जिन patients में it is persisting beyond 6 months, that will always be considered to be atypical. that will always be considered to be atypical, right? So this is the key point about ATNR. Appearance or disappearance exam में पूछा जाता है. Abnormal persistence is different from normal time of disappearance, right? Moros में भी ऐसा ही है. Normal time of disappearance 3 to 6 months. Abnormal persistence of Moro कब बोलेंगे? If it persists beyond 6 months, right? Look at the third image. A reflex is being checked. Which reflex is being checked here? This is the reflex which is called as palmar grasp reflex. When you stroke, suppose this is the palm of the child, you stroke the radial side. Suppose ये हाथ है बच्चे का, this is a newborn, right? If you stroke the radial side, nothing will happen. But if you stroke the ulnar side, the child will try to hold that object using the 4 fingers. Remember, child will not use the thumb. And when the child holds it like this is called as palmar grasp reflex. Palmar grasp reflex is also sometimes called as ulnar palmar grasp reflex, because predominantly it is mediated by stroking the palm on the ulnar aspect, not the radial aspect. So ulnar palmar grasp reflex. Palmar grasp reflex is a primitive reflex. It normally appears in a child around 28 weeks of gestation. So it appears quite early. तो पेट में ही जब 7 महीने की प्रेगनेंसी होती है, when 7-month pregnancy is there, 28 weeks of gestation, this will appear. And it is present at every child at birth. What is the normal time of disappearance? Normally disappears around 3 months of age. Normally disappears at 3 months of age, right? इससे मिलता जुलता एक milestone भी है, what you call as palmar grasp as a milestone. Palmar grasp as a milestone tends to appear between 6 to 7 months. कुछ books कहती हैं 6, कुछ कहती हैं 7. So 6 to 7 months of postnatal age. And then it quickly evolves into pincer grasp, where the child learns to use a thumb and index finger. See, palmar grasp reflex अलग होता है, palmar grasp milestone अलग होता है. So there is a difference between palmar grasp as a reflex. There is a difference between palmar grasp as a milestone. In a newborn, you stroke like this, newborn holds it like this. This is palmar grasp reflex. In a 7-month child, you do like this, child will not hold unless he wants to voluntarily hold. So palmar grasp milestone is a voluntary holding. बच्चे का मन करता है, if the child feels like holding, he will hold, otherwise he will not hold. And that is a milestone which appears at 6 to 7 months. So please keep a difference between these two. This is a common mistake I see every year. Palmar grasp reflex अलग है, palmar grasp milestone is different. Though both sound same, but they are different, right? Let's move further. Look at this child. There was a newborn who was born, who was having these multiple lesions, white colored papules on the nose and in the cheek region. What are these lesions called as? There are 2 types of descriptions of this lesion. They are typically called as milia. They are also sometimes called as sebaceous gland hyperplasia. Sebaceous gland hyperplasia. Right? Sebaceous gland hyperplasia. Milia appears as yellow-white papules. They are present sometimes in normal children. Do they require any therapy? No treatment is needed in these patients. They will improve without therapy. There is a similar sounding thing called as miliaria. देखो miliaria and milia same नहीं होता है. Miliaria occurs due to inflammation and involvement of acrine type of sweat glands. Miliaria, I don't know what it is called in regional languages, but in Hindi, it is called as ghamoriya. You know, once the summer season starts, you have those talcum powder ads coming up. So, usme chubti jalti garmi ka mausam aaya, right? They're the typical tagline in the advertisement is there. Those lines are there. So that is miliaria. Miliaria is inflammation of acrine sweat glands. Miliaria can occur at any age. Milia can occur at any age, but milia is more common in newborns, and it is a self-limited phenomena. So key point to remember, milia is sebaceous gland, miliaria is sweat glands. And both of them, if you practice past questions, they are past MCQs. And don't get them wrong in the paper, right? So milia versus miliaria, they are separate. Let's move further and let us meet Patel Vadharia in Gujarati. Great to know that. Chalo, I also learned something new. So we keep learning from each other. Look at the next image. So you have an image of a child. This newborn was born. He was totally asymptomatic. But this newborn is having these blue-black macules on the back, buttocks, and thigh region. So what are these called as? These are what you call as Mongolian spots. They are Mongolian spots. They are not salmon patches. Mongolian spot को कैसे describe किया जाता है? They are way more common than a salmon patch. Mongolian spots are described as blue-black macules, which are typically found in the back. They are found in the buttocks, and they are found in the posterior part of thigh. They are found in posterior part of thigh. Why do they occur? There are many theories. Normally, the currently accepted hypothesis is it is a type of neural crest migration defect. But fortunately, this neural crest migration defect, it does not usually cause much problems, and they tend to slowly disappear in 1 to 2 years. They tend to disappear in 1 to 2 years. Is it life-threatening? No. Is it malignant? No. Is there malignant potential? No. Are they palpable? No. Do they require any therapy? No. They disappear in 1 to 2 years. So as compared to other transient phenomena which disappear in a few days, Mongolian spots take a longer time to disappear. So if the MCQ examiner says that which neonatal phenomena disappears much later beyond infancy, the answer will be Mongolian spot. Extra edge point. There is a child where Mongolian spots were extensive, covering the entire back and buttock, and they tended to persist even beyond 2 years. Would you suspect a syndrome? Yes. There are two syndromes. You must have heard about them: Hurler syndrome and Hunter syndrome. Hurler syndrome and Hunter syndrome, they are a type of mucopolysaccharidosis. Hurler is type 1 and Hunter is type 2. Both of them can have extensive, non-resolving Mongolian spots. But if you find a Mongolian spot in a child, you will always consider it to be normal, right? Hurler and Hunter syndrome में only Mongolian spot नहीं होगा. They will also have other problems like hepatosplenomegaly, Coats facies, dysostosis multiplex, the bony lesions, etc. I'm not going into that topic. So just remember that this is how Mongolian spots will look like, right? So good evening, Rahul. You've joined late, but join from here and you can see the remaining things later. So let us look at the next newborn. There is a newborn who is born and he's having a distinct discoloration. One half of the body is dark pink in color, one half of the body is pale in color. What do we call it as? This is so you can see one half of the body is pale and one half of the body is dark. It is dark red in color. This is what you call as the likely diagnosis in the child is Harlequin color change. Harlequin color change. Nahid Raza, all except wale questions create problems for everyone, and that is why examiners put them. The only way to overcome that is practicing more and more grand test, practicing more and more practice tests. MCQ solving tricks. Again, I am saying it in a live session. Coming days, once these IBQ based sessions are over, I'll be coming and talking about some MCQ solving tips, right? But right now, let us stick here. Harlequin color change. Harlequin color change is an autonomic dysfunction involving the autonomic nervous system, and it is usually considered to be self-limited. It is considered to be self-limited, does not require any therapy. Does not require any therapy, right? So it is self-limited and usually does not require any therapy. So Harlequin color change is a self-limited phenomena. Yaad kaise karna hai? Easy way to remember. Harlequin. Harlequin. Do you remember? Do you know who Harlequin is? Yes, Harlequin is the girlfriend of Joker of Batman, played beautifully by Margot Robbie in Suicide Squad. Suicide Squad, the second one which came, was an excellent movie, and a sequel is also in works. Harlequin, if you look at the comic book history, she was a psychiatrist who fell in love with Joker and became a psychopath. Harlequin has two personalities. Sometimes she helps the law enforcement agencies. Sometimes she likes to kill people. So same person has two types of personalities, one pale or normal and one dark. So probably the person who described this would have been a Harlequin fan, and he described it like Harlequin color change. We don't know whether it was described like this or not, but if you remember like this, you will never forget. Our brain has a tendency that we forget good things, but we tend to hold on to stupid things. So attach the two together and you will have a better retention. So Harlequin color change, self-limited phenomena. Parents ko reassure karenge, nothing to worry. In a few days, it will come back. the normal skin color will improve. Next, we move to this phenomena. This sounds like Harlequin, but it is not Harlequin color change. This is what you call as Harlequin ichthyosis. This is what you call as Harlequin ichthyosis. Harlequin ichthyosis में there is intense dehydration and the splitting of the skin. The epidermis splits into diamond-shaped plates. This is called as Harlequin type of ichthyosis. It is not a transient phenomena. It is not a self-limited phenomena. Remember this. It is not a self-limited phenomena. The child will have bleeding from the cracks in the skin. The child will have difficulty in feeding. Child will have recurrent infections, and there is a possibility the child may even die. And what is the most common gene abnormalities associated with Harlequin ichthyosis? It is ABCA12 gene abnormality. So ABCA12 gene mutations are responsible for Harlequin ichthyosis. Treatment is majorly supportive. Along with that, it has been found that use of retinoids, they improve the symptoms in some of these patients, but they have a high mortality. They are found to have high mortality in most of these patients. Most of them die. They do not survive, right? So this is Harlequin ichthyosis. Let's move further and look at this phenomena. What is this? Can you see? Can you answer what is it? This is what you call as syndactyly. There is a fusion of digits, right? Syndactyly, fusion of the digits. Syndactyly is directly a MCQ asked in FMGE exam 3 years back. Indirectly, as a part of a syndrome, it was asked in AIMS entrance exam before INICET came. So syndactyly is fusion of digits. What are the reasons for syndactyly? Syndactyly, if someone says, what is the common syndrome associated with syndactyly, you will name a syndrome known as Apert syndrome. So the person is likely to suffer from Apert syndrome. There are 1,000 causes. Sometimes syndactyly occurs without any reason in the patient, right? But if they say if it is a part of a syndrome, which syndrome will you suspect? Apert syndrome should be suspected in the patient. So this is syndactyly. Look at the next image. Craniosynostosis syndromes. How to distinguish? Extremely important from INICET and NEET PG. If you are FMGE student, you can listen to it. Obviously, you will benefit out of it. But it is a must thing how to distinguish between these two for NEET PG and INICET exam. Now, what is craniosynostosis? नाम में लिखा है craniosynostosis. Cranial bones fuse prematurely, right? So craniosynostosis is characterized by premature fusion of the cranial sutures. Now, obviously, if there will be a possibility the brain will not get space to grow, and so the child will develop mental retardation, low IQ, and various other related abnormalities. Craniosynostosis has been described as a part of 16 syndromes. The remaining 14 we will read if we take up pediatrics as a specialty. But for entrance exam, 2 are important. Look at the first syndrome. The first syndrome here is Apert syndrome. This is what you call as Apert syndrome. Can you see the syndactyly here? And this is what you call as Cruzen syndrome. So Cruzen syndrome and Apert syndrome. How do you distinguish between them? Apert syndrome के अंदर there is a classic triad. 3 चीजें हैं which you will look out for in the exam. In these patients of Apert syndrome, you will have brachycephaly. So flattened skull called as brachycephaly will be there. This is the type of craniosynostosis. So flat skull. Second, they will have mid-face hypoplasia. So middle part of जो face है वो hypoplastic होगा. And if you see laterally, ये अंदर की तरफ it will be pressed inside. If you see laterally, so mid-face hypoplasia. And third feature is bilateral syndactyly. Bilateral syndactyly is always present in the patient. These hands are called as mitten hands in the patient. So this is what you call as mitten hands. So brachycephaly, mid-face hypoplasia, bilateral syndactyly, Apert syndrome. How to identify Cruzen syndrome? Cruzen syndrome के अंदर you will always find the patient to be having. Can you see proptosis? There is no triad here, but some common features can be seen. Can you see strabismus or squint in the patient? Right? These patients also have brachycephaly. So flattened skull can be seen in Cruzen syndrome also. And they are also having beaked nose. Beaked nose. And lastly, syndactyly is sometimes found. Syndactyly is sometimes found, but it is not bilateral and it is not a characteristic feature. So it is not a characteristic feature. Remember, this is how we distinguish between them. And patients of Cruzen syndrome have a high risk of developing Chiari malformations. Chiari malformations are a type of posterior fossa brain malformations which occur. So this is how you will distinguish between Apert syndrome versus Cruzen syndrome. Extremely important, and just revise it once again before you sit for the exam. Right? Let us move further. Now, this is the one which you people were asking. See, I have discussed it in most places where I take the class, so you already know it. But cerebral angiography shows this appearance. When you do cerebral angiography, you can see here that there is a puff of smoke appearance seen here. Puff of smoke appearance. And puff of smoke appearance is typically seen in patients of Moya-Moya disease. It is not Moye-Moye, it is Moya-Moya disease. Right? And Moya-Moya disease children, it's a bad thing to have because they have an extremely high risk of early onset stroke in the patients. Before they die eventually of stroke, they will keep on having multiple TIAs and strokes early in the life, and so they will have all those hemiplegias, visual issues, visuospatial deficits. Later on, the cause of death is always a severe stroke in the patient. So stroke is the cause of death in these children. Yes, Trinath Mishra is absolutely right. ICMC territory, these puff of smoke and these vessels abnormalities are found. Let's move further. Now we are moving into spotter region. Question will say there is a child with macrocephaly, bada se, tall for age in the childhood, low IQ, either autism or ADHD, and facial dysmorphism. What facial dysmorphism can you see? Can you see that this child is having a elongated face? He is also having large ears. Diagnosis, yes, the child is likely suffering from Sotos syndrome. The child is likely suffering from Sotos syndrome. And Sotos syndrome is produced by abnormalities of which gene mutation? NSD1 gene mutation. NSD1 gene is found on chromosome number 5. So NSD1 gene mutations are responsible for producing Sotos syndrome in the patient. This is not Fragile X. Fragile X syndrome child will have macrocephaly, large ear, large jaw, large testis. Actually, the hallmark of Fragile X syndrome is bilateral macroorchidism. If the examiner fails to mention it, and if they say the patient is having facial dysmorphism along with autism ADHD being the prominent findings, the likely diagnosis is Sotos syndrome. Eventually, many patients of Sotos syndrome and Fragile X are difficult to distinguish clinically, and so we need to go in for genetic tests like fluorescent in situ hybridization, where you are able to make the diagnosis, right? So Sotos syndrome is the diagnosis. Why it is not Fragile X? Because if they are making Fragile X and they both mention Sotos syndrome, Fragile X, they will always mention bilateral and large testis in the patient, right? Infertility they will mention in the patient. Here it is not mentioned. Look at the next scenario. This is a child who's having periorbital edema. The edema is more in the morning. The child is also passing frothy urine. Which investigation would you like to do? This child is having all the features suggestive of likely nephrotic syndrome. And so which investigation would you like to do? You will like to do urine protein. If you do urine protein and you find patient is having massive proteinuria, the patient is having massive proteinuria. Yes, Aladi Vinay, congenital giant gonad CGG repeats are there in Fragile X, not in सोटोस सिंड्रोम, एब्सोल्युटली राइट। फ्रजाइल एक्स में हम ऐसे ही याद करते हैं कि सब चीज बड़ी है बट काम नहीं करती है, सो दे हैव अ लार्ज हेड बट लो IQ, टेस्टिस आर लार्ज बट इनफर्टिलिटी एंड सो ऑन। सो यहाँ पर व्हाट इज द लाइकली इन्वेस्टिगेशन विल डू? Urine protein, you will look for massive proteinuria. If present, the likely diagnosis in the patient will be nephrotic syndrome. How to quantify massive proteinuria is a separate topic in itself, because we have to finish off by 9:45 or 9:50 maximum this session. So I will not go into those details, but also remember for the exams how you define proteinuria. In adult, only more than 3.5 gram of urine protein in 24 hours is good enough. In children, uh, urine protein excretion, multiple ways are there. You can do a protein creatinine ratio, you can do body surface area related measurements, sometimes dipsticks can be used, and massive proteinuria is written as 3 plus or 4 plus urine protein. So किसी भी question में, in any question, if they mention 3 plus या 4 plus urine protein, it is indirect evidence patient is having nephrotic syndrome, right? सीरम कोलेस्ट्रॉल करने का राजेश फायदा नहीं है, बिकॉज कोलेस्ट्रॉल, yes, it can be elevated, but it is not diagnostic or does not have any other value apart from just being a finding in the patient, and it is not a hallmark finding. So urine protein करेंगे, सीरम कोलेस्ट्रॉल मेंशन होगा ऑप्शन में, but that will not be the answer, right? Yes, nephrotic syndrome in children, it is caused by minimal change disease, absolutely right. Now look at the case scenario. की वर्ड्स देखने हैं, जब एग्जाम में आएगा तो लंबा केस बन के आएगा. Here I am highlighting the key words you need to look out for. So they will say a 1.5-year-old boy, abdominal mass, weight loss, loss of appetite. So something serious. Episodes of hypertension and appearance as shown. This appearance where a black discoloration is happening around both the eyes is called as bilateral raccoon eyes. Bilateral raccoon eyes, also called as bilateral panda eyes. So in case you have bilateral raccoon eyes or bilateral panda eyes, along with abdominal mass and likely malignancy, weight loss, loss of appetite, the likely diagnosis in the patient is going to be neuroblastoma. So what is the likely diagnosis here? It is not Wilms tumor. यही गलती आप करते हैं. I was waiting for you to make that mistake. Neuroblastoma shows bilateral orbital metastasis. Orbital metastasis is absent in patients of Wilms tumor, right? So neuroblastoma with orbital metastasis is the likely diagnosis here. We will come to Wilms tumor also in some time. So neuroblastoma with orbital metastasis, right? Pheochromocytoma will not occur in a 1.5-year-old boy. A child is not a miniature adult. And episodes of hypertension, episodes, जो Wilms tumor होता है, persistent hypertension होता है. In patients में episodes of hypertension occur because of release of catecholamines. It's a tumor arising usually from the adrenal medulla, and so it has active catecholamine producing secreting cells for neuroblastoma. And इसी के अंदर एक extra edge point, overlap topic, integrated question. Name the monoclonal antibody which is useful in patients of neuroblastoma. Can anybody tell? Monoclonal antibody in neuroblastoma which has been employed for use. The monoclonal antibody is dinutuximab. Dinutuximab, याद कर लो. It is mentioned in Nelson. Dinutuximab is anti-ganglioside GD2 antibody. GD2 ganglioside जो होता है, this is found overexpressed in tumor cells of neuroblastoma. If GD2 positivity is there, these patients show a very good response to dinutuximab. So antibody useful in them. No, Meet Patel, orbital metastasis is not the only difference. Age group is also a difference. Neuroblastoma tends to occur in children less than 2 years of age, whereas Wilms tumor tends to occur in a child between 2 to 5 years of age. Neuroblastoma children will have bony metastasis, they will have catecholamine production and episodes of flushing, episodes of headache, along with the enlarging abdominal mass. Wilms tumor patients clinically will be 2 to 5 year child, unilateral abdominal mass, and this mass will be restricted to one side of the body, and they will have sustained hypertension along with hematuria sometimes. But orbital bony metastasis is often absent. You can do radiology, and radiology will always tell you the clear diagnosis between them. Biopsy is seldom needed in these patients, right? Let us go further. Look at this case scenario. 6-year-old boy, similar image asked in INICET exam already. 6-year-old boy needs multiple blood transfusions, and needs blood transfusion means somewhere where blood forming X-ray skull is shown. This type of appearance of X-ray skull is what you call as crew cut appearance. This is what you call as crew cut appearance. Crew cut appearance also called as hair on end appearance. There is enlargement and widening of the trabeculae present in the superficial narrow spaces of the skull bones, and hair on end appearance or crew cut appearance is suggestive of chronic hemolytic disease. Now, which chronic hemolytic disease requires blood transfusions throughout life? The likely diagnosis in the patient is beta thalassemia major. I hope you know कि beta thalassemia के 3 types होते हैं. Thalassemia has 2 types, alpha and beta. Beta has further 3 types: beta thalassemia major, intermediate, and minor. Minor is also called as straight. Minor वाला जो होता है that resembles iron deficiency anemia. On the other hand, major is transfusion dependent, and these are the patients who always require blood transfusion. Extra edge point, recent update, potential MCQ. मैंने इसके ऊपर एक रील भी डाला था recently. Name the new gene therapy, also called as cellular therapy, available for beta thalassemia major. Yes, it is available in India now. उसका नाम है बेटी autotemcel, also written as Betty cell therapy. इसमें we take hematopoietic stem cells and using a lentiviral vector, we alter and change the defective gene causing beta thalassemia and then give as a transfusion. Beta-betiglogen has been approved for use in beta thalassemia major patients between 5 to 50 years. It's a costly therapy, but it is likely ऐसा लगता है कि अगले dramatic improvement in the life quality of these patients will happen, right? So betiglogen, autotemcel. Let's move further. The question will say 7-year-old vegan. Look at the keywords. Vegan का मतलब no animal product, not even milk and milk related products. Anemia is present. Second clue, peripheral blood film is showing this. What is this? This is a large neutrophil with multiple lobes in them. This is what you call as a hypersegmented neutrophil. So what are the clues? See, solving clinical questions, particularly those with image-based questions, they are like watching a detective series or reading a detective novel. I don't know whether you like them or not. Once upon a time, when I used to have time for myself, I used to read a lot of these Hercule Poirot-based novels. They used to be wonderful, apart from the usual thrillers, Agatha Christie and similar Sherlock Holmes-like things. So if you look at them, there are always clues that these people look out for. And MCQ exams are no different from them. When a patient, they will describe a 2-line or 3-line question, it is always easier to make the answer if you know what you need to look out for. एक बहुत important tip दे रहा हूँ. In case there is a patient with a rash and fever is mentioned, you should always think of a likely infectious cause. But if they don't mention fever and it is a otherwise normal child with a rash, you should think of non-infectious causes like allergies, like drug reactions, like micronutrient deficiencies. For example, zinc deficiency can cause rash in the absence of fever. And sometimes atopic dermatitis will cause a itchy rash in the absence of fever. So look out for keywords, and more MCQs you solve, the more your skills will develop, right? This is the one in between advice I wanted to share with you. So hypersegmented neutrophil, 7-year-old vegan, anemia present. What is the likely diagnosis? Patient is suffering from megaloblastic anemia. Now, megaloblastic anemia can occur due to both B12 deficiency as well as folic acid deficiency or folate deficiency. तो दोनों में से क्या आंसर होगा यहाँ पे? The answer is likely to be B12 deficiency. Why B12? Because it is a vegan patient, and vegan patients are predisposed for B12 deficiency. Hint word, अगर क्वेश्चन बोले फोलेट डेफिशिएंसी सस्पेक्ट कर रहे हैं, कब सस्पेक्ट करेंगे? इन केस देयर इज एक्सेसिव गोट मिल्क कंजम्पशन. Goat milk is poor in folic acid level, and it also has substances sometimes which interfere with the folate metabolism. You know that DHF, THF cycle, tetrahydrofolate cycle that you read in biochemistry. So goat milk consumption agar question mention karega, to clue kya hoga? Folate deficiency is the likely cause. But here it is a vegan patient, so it is B12 deficient megaloblastic anemia, right? तो छोटी छोटी चीजें हैं, 80% चीजें जो मैं बता रहा हूं, you know it, but it is a revision session, and additional things if you find, you can always write them to your revision notes. Let's move further. Easy one. This is a child who has been breastfed for more than 2 years. I'm zooming it a bit. Breastfed for more than 2 years. Suddenly, he was weaned from breast milk, and there is edema along with features of malnutrition. So, edema with malnutrition. This is a child. Can you see the edema? There is also pot belly in the child, and this is a sign seen in here. This is what you call as here sign. This is what you call as here showing a flag sign. Alternate areas of pigmented, depigmented, and pigmented here. So flag sign is present. So what is the likely diagnosis? Yes, the likely diagnosis is Kwashiorkor. Likely diagnosis is Kwashiorkor. Kwashiorkor is also called as edematous malnutrition. It is also called as fat sugar baby. It is also called as, yes, Aladi Vinay, if a person doesn't eat much greens, that can also be a clue for folate deficiency. Absolutely right. Absolutely right. So Kwashiorkor is fat sugar baby. Kwashiorkor is also called as maladaptive PEM, because adaptation is not proper. And what is the most common cause of Kwashiorkor to happen? It happens due to severe protein deficiency. So it occurs due to severe protein deficiency in the patient, right? So this is what you call as Kwashiorkor. Likely diagnosis, Kwashiorkor, right? Let's याद कर लो, अगर पूछें कि क्या हमेशा प्रेजेंट होता है, edema along with mental changes like apathy, irritability, excess lethargy, they are always present in a patient with Kwashiorkor. तो ये दो चीजें हमेशा होती हैं. Flag sign may or may not be there. Dermatitis rash may or may not be there. Pot belly may or may not be there. Hepatomegaly may or may not be there. But edema with mental changes will always be present in the patient. Let's move further. Now, this is an easy one. Starvation is present. So child is adapting. There is no edema. Loss of hair is there and visible severe wasting. Can you see these wrinkles on the face and loose skin folds here? So wrinkles are present on the face and there are loose skin folds. So everything pointing it to a diagnosis of marasmus. Marasmus. Why? What produces marasmus? It is produced by severe caloric or carb. Flesh and bones PEM. Mara, M-A-R-A, mara hua sa bachcha. So flesh and bones PEM is the other name. It is also called as adaptive PEM because the child adapts and there is never any edema in the marasmic child. So when life gives you, I say it in every class, so many of you have heard it already. When life gives you malnutrition, be like marasmus, not like Kwashiorkor. Kwashiorkor child does not adapt and so has higher complication, higher mortality. Marasmic child adapts, and any person in this world who adapts will always have a better survival. देखने में Kwashiorkor child looks to be healthier. Looks can be deceptive. Looks are always deceptive. Remember that point as well. Many of you know it already. So don't go with the looks of the child. Don't go by the looks of the person. See what is inside, what is happening, what is the cause, how the patient is responding, and you will find that person who adapts is marasmus. He will always have a better outcome. Let us move further. Aditi Gupta, there are no apparent skin manifestations and rashes like crazy pavement and flaky pin dermatitis are described for Kwashiorkor, not in marasmus. Monkey-like facies, yes, old man appearance. Let's move further. Now we are into some tricky scenarios. There is a child. Yes, Aditi, life lesson. So otherwise, what happens is everything becomes, boring. Same chalta rehta hai. We are all running into this. Kabhi thoda bahut beech mein, we should always keep mixing up the things a bit. So look at this case scenario. Question is saying, 5-year-old unimmunized child. Unimmunized is a keyword. Presented with high fever, malaise, cough, and redness over the tonsils evolving into a white membrane. So white membrane is the clue. Image of the child is shown. What is the likely diagnosis? You can see this child is having the so-called bull neck appearance. So what are the clues here? Bull neck appearance. This is how bull neck appearance looks like. So bull neck appearance. लोग कहते हैं कि sir, how to distinguish it from parotid swelling? Parotid swelling will be involving the angle of the jaw. It will be in the parotid region, and this will cause displacement of the ear. Whereas these patients will have a neck swelling, and this neck swelling will be associated with high-grade fever and a white membrane, the so-called pseudomembrane formation on the tonsils. So it is a faucial diphtheria. What is the likely diagnosis? Yes, the likely diagnosis in the child is diphtheria. The child is having diphtheria. Diphtheria, what are the key points? I knew कि हमें जल्दी से rush करना पड़ेगा, so I've already written here. You can just go through them. Cause is Corynebacterium diphtheria. Incubation period is 2 to 5 days. In fact, it has the shortest incubation period among most vaccine-preventable diseases. I just told you a possible MCQ. Name the vaccine-preventable disease with the shortest incubation period. I'm talking about the national immunization schedule. So 2 to 5 days incubation period is the shortest for diphtheria. Pertussis has a longer incubation period. Tetanus has a longer incubation period. TB, you know. Hepatitis B, you know. Polio, you know. So incubation period is 2 to 5 days. Right? And most common type of faucial diphtheria. Aditya Pathak, voice change will occur in laryngeal diphtheria patients. Laryngeal diphtheria patients. Not in palatine or faucial diphtheria, right? Laryngeal diphtheria can have voice changes. So most common type is faucial diphtheria. Bull neck appearance due to enlarged cervical lymph node. Complication, remember, if it is a child, the complication is usually aseptic meningitis. If that is not in the option, you can take meningoencephalitis. But in case it is an adolescent or an adult, in case there is adults, in case of adults, the likely the likely complication is orchitis, also called as epididymo-orchitis. 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 And treatment in the patient is antitoxin, diphtheria antitoxin. It is a toxin-mediated illness, and antibiotics. You can use either penicillin G or macrolides as the agents, but you need to give antitoxin in the patient. And the cause of death in these patients is mostly due to a respiratory failure. So, yaad kar lo, cause of death in these patients is due to a respiratory failure caused by the pseudomembrane due to airway obstruction. That is the most common cause. Second common cause is carditis, the cardiac involvement, and third is the neurological involvement due to toxin. Right? Let's move further. Now we have a 6-year-old boy who presented with high fever, malaise, cough, and painful swelling at the angle of mouth interfering with feeding, as you can see here. See, when you examine a patient, unfortunately, I don't have a patient in front of you to show it, but it is very easy clinically to distinguish between a swelling, a bull neck appearance versus a parotid enlargement. So this is a child who's having a unilateral parotitis, and so the likely diagnosis in the child is mumps. The likely diagnosis is mumps. Look at the keywords: painful swelling at the angle of mouth. This angle of the mouth, this obliteration of the angle, the jaw angle, is responsible. And it is not involving the neck. It can sometimes interfere with chewing, speaking, and the child will have outward and upward pushing of the pinna as well in these patients, right? So the child is likely suffering from viral infection called as mumps. So mumps incubation period is 2 to 4 weeks. Period of infectivity, very important. It's a one-liner question asked some years back in NEET PG, 6 days before to 9 days after the swelling appears, right? Clinical picture, I have already explained to you. Complications of mumps. Oh, I made a mistake. Complications in these in mumps patient, you have these complications. The complication in a diphtheria patient are obviously respiratory failure leading to airway obstruction, right? It is the mumps patient where the complications include, in a child, you will have aseptic meningitis. Aseptic meningitis. Pardon me for the silly mistake. So you now understand when people ask me, sir, how to avoid silly mistakes? Nobody can avoid silly mistakes. The only thing you can do is correct your mistakes and go back to them before the exam gets over. So adults, you will have bilateral orchitis or epididymo-orchitis or epididymo-orchitis. I'm really sorry. I mentioned it there. The complication here was respiratory failure leading to airway obstruction, due to airway obstruction leading to death of the patient, and carditis and neural involvement can also there. And unfortunately, I mentioned it here. So please correct it, right? So mumps and serum amylase is high in 90% patients, and IgM ELISA is used for making the diagnosis. This is mentioned in OPGAI. Treatment in mumps patients is usually supportive. So treatment, mumps patients mostly improve by themselves, and supportive therapy can be given in most of these patients. Now we come to this scenario. Now this is an easy one. Unimmunized child presented with fever. He presented with cough, runny nose, red eyes, oral cavity lesion. So cough is there. Runny nose means, so cough is there. Runny nose means coryza is there. Red eyes, which are watery, means conjunctivitis is there. So cough, coryza, conjunctivitis are called as the 3 C's. 3 C's along with fever, along with oral cavity lesion, which are looking like rice grain lesion. These are what you call as Koplik spots. And you have a rash, which is non-itchy and started from the face and later involved the entire body. What is the likely diagnosis? Yes, the likely diagnosis here is measles. Measles is also known as rubella. Measles is also known as rubella, right? So keywords about measles. Measles, OPGAI 10th edition says incubation period is about 10 days. And so many of you were asking, कि sir, shortest incubation period vaccine preventable disease में measles का होगा? नहीं होगा. It is diphtheria which has the shortest incubation period, 2 to 5 days. According to GAI, it is average about 10 days. And so it tends to occur, the incubation period is slightly longer in case of measles. Period of infectivity is 4 days before to 5 days after the rash. It is a past AIMS MCQ, can come in INICET or NEET PG exam. Treatment is supportive. Vitamin A oral mega dose can be considered. It is not mandatory. Why do we give vitamin A? They can ask you in exam. Measles child has been diagnosed. Which micronutrient supplementation will you give? You will give vitamin A supplementation. Vitamin A supplementation, vitamin A deficient children have more severe measles, and measles patients tend to develop more features if they are vitamin A deficient. तो दोनों तरफ ऑपरेट होता है, so it is always better to give at least one oral megadose age appropriate to a measles child, right? So remember this key point. And about the complications of measles, we have already discussed in various forums and classes. Most common complication is acute otitis media. Most common cause of death in measles is pneumonia. And if they ask you rare, delayed, but uniformly fatal complication of measles, the answer will be SSPE. SSPE. Subacute sclerosing panencephalitis. Abhinaya and Adnan are asking, tell the vitamin A dose. Vitamin A dose will be age appropriate. If age of the child is less than 6 months, so you will give 50,000 international unit. 6 to 12 months, you will give 1 lakh international unit. And more than 12 months, equal to or more than 12 months, so 12 months is also there, so 2 lakh international unit. So the same dose that you follow for vitamin A deficiency. But there you give multiple doses, 0, 1, 14 days. Here, 1 dose needs to be given, and additional dose you will clinically decide, right? There is no guideline for that. ये थेराप्यूटिक डोज है जो मेगा डोज दे रहे हैं. देखो वर्ड लिखा है मेगा डोज. मेगा डोज हमेशा इतना ही होता है. मेगा डोज इज ऑलवेज दिस, राइट? The word like first disease, second disease, third disease, they are avoided. Yes, measles is called as first disease, but this nomenclature has been discarded because we know that there are many diseases like fourth disease which do not exist at all. So look at the next scenario. Unimmunized. Adnan Khan, 1-year-old baby, 2 lakh international unit देंगे. DKH, 1-year baby, if it is exact 1 year, 2 lakh international unit is given, right? It is not 1 lakh. It is less than 6 to up to 12 months, but not completed 12 months. That is what they mean when they say 1 lakh international unit in that age, right? Unimmunized baby presented with fever, cough, oral cavity lesions as shown, and non-itchy rash which started from the face. So measles-like rash along with oral cavity lesion. What are the oral cavity lesions you can see? Can you see? I'm trying to zoom in. Can you see these discrete rose-colored spots which are present on the soft palate? These are what you call as, these are rose-colored soft palate lesions. Rose-colored soft palate lesions which are discrete in nature. Typically seen, they are what you call as Forsheimer spots. This is how Forsheimer spots look like. So Koplik spot दिखते हैं like rice grain, and Forsheimer spots are rose-colored soft palate lesion. So Forsheimer spot with measles-like rash, what is the likely diagnosis? Yes, absolutely right. The child is suffering from rubella. Rubella is also called as German measles. Rubella is also called as German measles. देखो एक चीज है, एक वर्ड है. I often find many medical students not understanding the nuance. एक वर्ड होता है exantheme, right? When you read textbooks, unfortunately these days nobody reads textbooks, but textbook reading is a useful thing. Now the exams are near, so time is gone. But whatever branch you will be moving into in after clearing your PG entrance or when you crack your licensing exam, please read textbooks. There is no replacement for that, right? Fast food is not a replacement for ghar ka khana. Similarly, the concepts you make by reading textbooks, online lectures are only to help you and simplify the process, but they are not a replacement for the textbook. तो टेक्स्ट के अंदर वर्ड्स एक्सैंथीम एनेंथीम आर मेंशन्ड. एक्सैंथीम होता है any skin rash in the patient. So any skin eruption like macule, papule, vesicle is exantheme. And फिर word आता है enantheme. The word enantheme stands for a mucosal lesion, right? तो oral mucosa में जो lesion होंगे उनको enantheme बोलेंगे. So if there is a patient having vesicles, we use the word exantheme. If there is a child having Koplik spot or Forsheimer spot, we use the word enantheme. And remember, strawberry tongue is also a type of enantheme, right? So ये word है, ये कभी कभी एग्जामिनर डाल सकता है एग्जाम में, because examiners read textbooks, right? आगे चलते हैं. It's a cultural thing, right? But for exams, after you crack the exam, like there was a student who cracked the NEET PG, got his seat of choice, pediatrics obviously, because he was connected with me, and he said, "Sir, abhi mera I've joined pediatrics. How should I start preparing for super specialty exam?" I said, you are not here to solve MCQs alone. You are also here to treat patients. So please try to see the patient, learn the skills. Along with that, if you get time, you can always prepare on this side, right? So remember these keywords. So rubella, keywords, how the examiner will say, rubella will have fever with or without upper respiratory symptoms. There will be lymphadenopathy mentioned in the question. This is a very useful clue. What type of lymph nodes are involved? Suboccipital, retroauricular, and anterior cervical. There will be a non-itchy rash which starts on the face and goes to the trunk. Rash is macular and milder compared to measles, and Forsheimer spots are present, which are pink red spots on the palate. Treatment in these patients is supportive, and in general, postnatal rubella, which occurs after birth, is a milder infection compared to measles, right? So these are the keywords about rubella that you should know. Let's move further. And now we have an unimmunized child. We have an unimmunized child who presented with fever. The child presented with cough, fever, cough, polymorphous rash. Polymorphous means multiple types of morphology in the person. Rash was itchy. Very few rashes are infectious and itchy, remember. So this is a itchy rash. And by the time child presented, many vesicles with red base had appeared. I am trying to zoom in. Can you see there is a pink red discoloration on the base, and there is a fluid filled vesicle on top. This type of appearance of vesicles is called as dewdrops on rose petal appearance. और चिकन पॉक्स का जो रैश होता है, it comes on the trunk and then goes to the peripheries of the body and the face. So rash appearing first on trunk and itchy in nature and polymorphous and vesicles always present, the likely diagnosis is varicella. Varicella, absolutely right. Most of you are answering it correctly. I'm very happy to see कि आप लोग तैयार हो, but every diamond continues to be polished, and till the diamond, goes to the owner and it goes into the end user. So similarly, till your exams are, you crack your exams, keep revising multiple times. So varicella or chickenpox. Regarding varicella, what are the key points you would remember? Fever with or without upper respiratory symptoms, itchy rash coming on trunk going to the face, polymorphic rash, macule, papule, vesicle, और crops of lesions happen. Crop of lesion. Crop का मतलब एक बार में बहुत सारे lesions आते हैं. And when the patient presents to doctor, all types of lesions are present, but vesicles are the predominant lesion, and these vesicles heal with crusting. And the vesicles tend to give a dewdrop on rose petal appearance. Regarding varicella, few more points. Incubation period is 10 to 21 days. Period of infectivity is 24 to 48 hours before rash, till all the vesicles are crusted. Most common complication is secondary bacterial infection, followed by acute cerebellitis. So acute cerebellitis, cerebellum ka involvement, cerebellum ka inflammation can cause ataxia in the patient. So they can ask you in exam, which fever with rash or with viral exanthem in a child can cause ataxia as a complication due to cerebellum involvement? The answer will be varicella or chickenpox. Meet Patel, I'm coming to hand, foot, mouth disease. Just wait, I will tell there how to distinguish. And treatment in these patients is oral acyclovir. Oral acyclovir. What's up, doc? I'm fine. Thank you so much. Love to you also. Love to Prayagraj people also. No issues. You can join from here, and whatever we have missed, you can see the video again. It will immediately, like 10 minutes after the session is over, it will go up on the YouTube channel of DocTutorials. So you can see there and make the notes if you need. So treatment is oral acyclovir given for 5 days, started within 24 to 48 hours of rash, no benefit thereafter, and consider IV acyclovir in high-risk groups like immunodeficient or steroid-receiving patients. Thumb rule kya hai? Acyclovir need not be given in child less than 12 years. Above 12 years, you can consider acyclovir, and acyclovir, if you have to give, always give it within 1 to 2 days of rash. If you give it late, it is not going to be of much benefit. So key points. ये सारे पॉइंट मैंने इसलिए लिखे हैं because these points we tend to ignore and they are very prominently mentioned in OP Ghai 10th edition, the new edition which is there. Let's go to the next scenario. Fever, erythematous rash bilaterally on the cheeks, giving a slabbed cheek appearance. So erythematous papule will appear in the bilateral cheek along with fever and some URI symptoms. So this is the typical slab cheek appearance. What is the likely diagnosis? What is the likely diagnosis? सबको पता है parvovirus होता है, but you forget the name of the disease. The name of the disease is erythema infectiosum. Erythema infectiosum. आदित्य पाठक, अभी इसको सुन लेते हैं. About PDF, I'm not sure. DocTutorials management will decide. Like if we cannot pick and choose that we will give PDF for one session and not for other, but this will go for on YouTube or channel of DocTutorial. You can see it, take shots or write down the key points later also. About PDF, I'm not sure. I did not have a word with the management regarding this. I'm sleepwalking right now because I just came back to my home for taking the session after some days away from the city. So diagnosis, erythema infectiosum, also called as fifth disease. And what is the causative agent? What's up, doctor? Last words for January 20. January 20 means you are FMGE aspirant. January 20 का एग्जाम जो लिखेगा ये आपका लास्ट FMGE एग्जाम होना चाहिए. This is what you have to say. उसके बाद you have to get into internship and 2025 or 26 you have to crack your PG entrance exam. That should be the aim. That should be the only thing that should be there on your mind. And believe in yourself. हो जाएगा. Question लिखा होगा, answer लिखा होगा. You need to identify. So erythema infectiosum, what is the causative agent? It is caused by parvovirus. Parvovirus B19. Parvovirus B19, what is the rare complication? Rare complication is, there was an MCQ asked a recent INICET exam. Rare complication is transient aplastic anemia, also called as transient aplastic crisis. So these children can develop pancytopenia and can require admission in a hospital, and they may require blood product transfusion. But it is self-limited because parvovirus has a tendency to sometimes infect the bone marrow precursor. Transient aplastic crisis is especially seen in chronic hemolytic conditions, chronic hematological diseases like sickle cell anemia. तो आप में और मुझ में नहीं होगा, नॉर्मल बच्चे में नहीं होगा, but sickle cell anemia के patients में common है. Apart from that, there are multiple complications, most of them self-limited. It can cause congenital infection and fetal hydrops in pregnant lady. It can also cause arthralgias, aseptic meningitis, and Guillain-Barré syndrome, radicular neuropathies. But these are all self-limited and they tend to improve with time. So this is the point on which INICET question this year was asked. Let's move to the next scenario. Yes. Dr. Zamal is asking for NEET PG. Zamal, NEET PG exam will be there. You still have time for that. NEET PG exam. Try to give your best shot. Exams, NEET PG exam is more clinical. I personally feel it is tougher as compared to INICET paper, but NEET PG exam is a more spread exam, horizontally spread exam. Horizontally spread means INICET vertical spread hota hai. Vertical spread means same topics getting repeated every year. NEET PG, you cannot leave any subject, and every system in every subject you need to touch. Not the rare things, but important things. Like if you look at pediatrics, if you have 15 questions coming from pediatrics, there will be one question from malnutrition, one from short stature, one from nutritional indices, one congenital infection, one fever with rash condition, one or two questions from neonatal resuscitation, one from other topics in neonatology. Then there will also be 5 or 6 questions from systemic pediatrics, which will overlap with the medicine, pathology, and microbiology part. So you cannot say that I'm good in neonatology, so I will not read the other. So that is how it is there. And so at the end of the day, it's a more balanced paper. With all due respect, NEET PG is a more balanced paper compared to INICET, right? INICET images are there, but it's more of a lopsided and a single, horizontal, vertical spread of the questions are there. Let's move further. Scenario. Let us pick up speed now. Fever with or without upper respiratory symptoms, blisters or vesicles forming in the perioral cavity, oral cavity, palms, soles, and buttocks. Likely diagnosis, as you can see in the picture, hand, foot, and mouth disease. Hand, foot, and mouth disease. It is, in short, it is written as HFMD, typically caused by Coxsackie virus, Coxsackie A16. Second common cause is enterovirus 71. Enterovirus 71. Complications are rare, but 2 complications you need to remember. Some patients can develop myocarditis and some patients can develop aseptic meningitis. And INICET, there was one MCQ asked in related to this case scenario. MCQ was asked related to aseptic meningitis developing in a hand-foot-mouth disease patient. So it was a long case where they had mentioned it. So hand-foot-mouth disease is the likely diagnosis. Now coming to how to distinguish from chickenpox. Chickenpox rash is itchy. This rash is usually non-itchy. Itching can be there, but itching is relatively, the word is relatively rare in these patients. Second, the appearance of the lesion. In chickenpox, first of all, you will have a macule. Macule will evolve into a papule, and papule will evolve into a vesicle. And new lesions will keep appearing daily. So when the child presents to the doctor, he will have vesicle, but he will also have multiple types of other lesions. Here you have only blisters or vesicles forming. No progression and crusting happening, right? Crusting happens in chickenpox. Thirdly, chickenpox rash appears on trunk and then goes to the face. Here the rash appears in 4 specific locations: perioral cavity and oral cavity. It occurs on the palms. It occurs on the soles. And sometimes there is a rule we say, you are suspecting hand-foot-mouth disease, do not miss the buttocks, because buttocks are involved in about 20 to 25% patients. And many times the rash is prominent only on buttocks along with the oral cavity. And so that is how you distinguish between them. I hope, yes, centripetal rash in chickenpox and pleomorphic, all those things. Trinath Mishra, palms and soles are spared in chickenpox. And here you have the chickenpox is a truncal rash, whereas hand-foot-mouth disease is a peripheral rash, right? I think should be enough. And many of our fellow students have also given some very useful information and nuggets with you. You can note down all these points as well. And I'm really very proud of all of you, that all of you are preparing really hard. Go for it, but at the same time, do a balanced preparation. Don't miss out on subjects, the commonest mistake students make. Next scenario, fever with or without upper respiratory symptom, non-itchy rash, starting on the trunk, appears as fever subsides, and lesions on uvula as shown in the picture. So there are lesions, ulcers forming on the uvula, sometimes papules, majorly ulcers will appear on the uvula. These uvular lesions are called as Nagayama spots. They are called as Nagayama spots. So Nagayama, ab dekho keywords kya hai isme. Rash is like measles. It is non-itchy, but progression is like chickenpox. Chickenpox ke jaisa, coming on trunk, then going to the face. And rash appears only when fever goes away. Fever and rash are never present together. So fever goes away, within 12 hours, rash will come. That is the characteristic finding, and Nagayama spots mentioned. So likely diagnosis in the patient is roseola infantum. Roseola infantum, also called as exantheme subitum. Alternative names are also important. Also called as 6th disease in the patient. And what is the causative agent? It is caused by human herpes virus 6 followed by human herpes virus 7 and treatment in the patient is supported. देखो आगे के जो लीजन्स है उनमें सिर्फ स्पॉटर्स हैं, but here I'm going slow because they have a high likelihood of being asked in the exam. So although ये half an hour से काफी ऊपर चला गया है, in between we are also going, but I think it should not be an issue for you because I don't want to lose out anything which I have prepared and kept in my mind from entrance perspective, right? So I hope it's okay and we can continue. Don't worry, I'll not continue whole night. I'm also very tired. I have to take my dinner also, but we'll finish whatever we have decided. The entire ये PPT खत्म करके जाएंगे आज, right? So stay with me. So scenario, next scenario. Now do you have fever with or without upper respiratory symptoms? Generalized lymphadenopathy. Now look at the keywords. Generalized lymphadenopathy, hepatosplenomegaly, and palatal hemorrhage is occurring at the junction of soft and hard palate. This is the clinching point. This is the clinching point. हर क्रिकेट मैच में एक होता है ना मैच चेंजिंग पॉइंट, उसी तरह यहां पर भी मैच चेंजिंग पॉइंट. आई डोंट वांट टू टॉक अबाउट इट, बट वर्ल्ड कप फाइनल में रोहित शर्मा का विकेट, देयर आर अदर रीजंस आल्सो, बट रोहित शर्मा का विकेट गिरना एट अ पर्टिकुलर पॉइंट वाज मैच चेंजिंग एट दैट मोमेंट एंड द मोमेंटम शिफ्टेड आफ्टर दैट. तो सिमिलरली यहां पर सिनेरियो में मैच चेंजिंग एमसीक्यू में डायग्नोसिस क्लिंचिंग पॉइंट क्या है? Palatal hemorrhage at the junction of soft and hard palate, as you can see, and they will mention it. So what is the likely diagnosis in the patient? The likely diagnosis in the patient is infectious mononucleosis. And infectious mononucleosis is previously called as kissing disease. Kissing disease word is not applicable in India, not because we don't kiss, we do, but kissing disease is found in adolescents. In United States, adolescent age group is more commonly affected, where it is spread through kissing or close contact. In India, most of the cases of infectious mononucleosis or EBV infection occur in the first decade, where children are more concerned with they not going to school or missing their maths homework. So they are not thinking about kissing. So kissing disease term is not applicable in India, but the word has stuck around because of the Western textbook. So infectious mononucleosis, what is the cause? It is caused by Epstein-Barr virus. And I hope you also know that these children can have a rash, especially when beta-lactams like ampicillin or amoxicillin is given. So rash appearing with ampi or amoxi can also be a clue to infectious mononucleosis as the likely diagnosis. Dr. R is asking how many PYQs can we expect in upcoming FMGE? It is very difficult to say. I don't make the paper. I have no idea. But at the same time, direct repeats are less. Indirect repeats are many. So don't miss out on the previous year question, but only previous year question will not make you crack the FMGE exam. You need to read the topics rather than the questions themselves. Yes, Meet Patel, Rohit did his job. I was saying match changing scenario. Rohit always does his job, but we all can always have a bad day. Let's just hope and pray that our bad day doesn't come in the actual time when we have to sit in the exam. And don't worry, here the exam, when you sit in the exam, answer will be written there. तो अगर आपने प्रिपेयर अच्छे से किया है, ऑल यू नीड टू डू इज आइडेंटिफाई एंड मार्क इट देयर, राइट? सो आर कह रहे हैं करते सब है बताता कोई नहीं है. लेट्स नॉट गो देयर. बच्चे सीधे सीधे. मीत पटेल, इंडिया के बच्चे बिल्कुल सीधे नहीं है. इंडिया इज द मोस्ट पॉपुलस कंट्री इन द वर्ल्ड. ऐसे नहीं हो गया है. देखो, इंडिया मोस्ट पॉपुलस कंट्री जो है, ठीक है, वो है फॉर अ रीजन. And this is to be taken in a positive way also. Yes, there are population related issues with us, but at the same time we also have a young dynamic workforce, and if given the right direction, I think we can all do wonders for our country, and we are going to be developed in the coming few decades. So right, so let's look at the next scenario. Vicky Dhankar, आज के मैच का पता ही नहीं है. I'm sleepwalking. I didn't even realize there was a match today. Let's go. Let's move. So fever with black necrotic lesion on the foot. So let us look at the questions. Fever with black necrotic lesion on the foot. The necrotic lesion has been shown. You know what it is called as. This is what you call as scar formation. The child will have headache and there will be splenomegaly in the patient, and blood is showing hyponatremia along with thrombocytopenia. Vivek Podal, I'm not the best, but I try to do the best I can, right? So best word bada tricky hota hai. So and love to you also. My love to all Nepalese people also, and obviously all Indians and everyone listening to this video. So if you have a scar, fever, headache, splenomegaly, and low platelet count with low sodium. The likely diagnosis in the patient is rickettsial infection. And which rickettsial infection can present like this? He is suffering from scrub typhus. Scrub typhus typically caused by Orientia susu-gamushi. Orientia susu-gamushi is the causative agent. What is the drug of choice in these patients? The drug of choice in the patient is doxycycline in all ages. Normally, doxycycline is avoided in young children, but here benefit outweighs the risk, and doxycycline in all ages need to be given in these patients. Usually for about 7 to 10 days we give. Normally, इसका cutoff क्या होता है कि if fever stops, you give for 3 additional days after the fever has subsided. Fever subsidence takes about 4 to 5 days, and then you give another 3 days so that no relapses occur. So total duration comes around 7 to 10 days, and that is the drug of choice. Rajesh Kumar is saying, you look super cool every time. Looks can be deceptive. I'm really tired right now. I didn't have time to change this, t-shirt also. So normally I don't take sessions, if you have seen, in t-shirts or sweatshirts. That's my thing. So I always wear a shirt while taking. I try to be professional, but today I was running short on time. So yeah, thank you. So you're best for us, Aditya Pathak. I don't know. I hope I am best for you. So let's move further. DU is saying, how many marks could we expect from PD and FMG? Marks, though, you will decide how many you are able to mark correctly. Direct questions from pediatrics, about 15 in FMG exam. Overlap questions with other subjects, another 5 to 7 you can add. So 15 to 20 questions every year, FMG exam, they are asked. Next question. Now, 3-year-old child. Abdominal mass is there. One half of the body is bigger than the other. So one half of the body bigger than the other is called as hemihypertrophy. And so you have 2 clues. There is a child with hemihypertrophy and abdominal mass. Name the tumor occurring associated with hemihypertrophy. It is Wilms tumor. And so the child is likely suffering from Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome is a syndrome in which there is a 60% risk of developing Wilms tumor. So the child is likely to have what abdominal mass? It is Wilms tumor. Beckwith-Wiedemann syndrome has Wilms tumor. These children have hepatoblastomas. So it is not only Wilms tumor, याद कर लो. तो hepatoblastoma भी होता है, तो you need to watch for AFP levels. तो MCQ बन के आ सकता है. In fact, there is already an MCQ on this in older JIPMER papers when INICET was not the common paper for Central Institute. तो उसमें था कि there was a Beckwith-Wiedemann syndrome child diagnosed. His ultrasound KUB is normal. Which other test you would like to do to watch for a particular malignancy? One option was do serum AFP level, because hepatoblastomas can also occur apart from Wilms tumor. So watch for AFP levels. These children will have hemihypertrophy. So one half of the body will be bigger than the other. These children will have aberrant earlobe creases. So kaan ke upar in the pinna, you will have earlobe creases present. These children will have omphalocele. You know what is omphalocele? There is herniation of the abdominal content in the umbilical cord region in a sac, and these children will have macroglossia, large tongue. Related to Beckwith-Wiedemann syndrome. Let us go. Let us go to the abnormal facies. Key points. Now we are into spotter things. Abnormal facies. What is this abnormal face looking like? Can you see frontal bossing? Can you see pinched nose with flat nasal bridge? And there is a forward protrusion of this part of the child. This is what I am just deleting this so you can appreciate the photo better. This is a child who's having a so-called chipmunk facies. And if examiner says chipmunk facies is commonly seen in which condition? It is most commonly seen in beta thalassemia major. It can occur in other conditions also, but most commonly seen in beta thalassemia major. This is an infant having wrinkled skin, wrinkles on the face. So the child is having monkey facies, also called as old man facies. So monkey facies और old man facies ऐसा दिखता है. ये सारी photos mind में imprint कर लो, 2 बार 3 बार देख कर जाना. When you are doing revision, just save this video और इसको 2x पे सुनना है, right? आगे आगे skip करके, so that things are fresh in your mind. Even if you write down your own notes, the stupid things I'm telling on the side, they are not stupid in a way. I know what I say. My tendency, my understanding is that if someone says a few things, things get embedded in your mind along with the photograph. And so you have a better recall in the exam. More about it, we'll talk later. So monkey facies, old man facies, typically seen in marasmus child. Look at the third condition. This is a child who has curly hair, blue eyes, bulbous nose, wide oral aperture, or dant dekho, look at the teeth. Can you see pointed, sharp, demon-like teeth, vampire-like teeth? This face is what you call as elfin facies. Dr. Zamal, as I said, I have no idea whether PDF will be provided by the management or not, because I'm taking on behalf of DocTutorials. So they will be able to tell you better, but 100% this video will go up on the YouTube, right? That is what we will try. So elfin facies is typically seen in patients with Williams syndrome. Williams syndrome, and Williams syndrome patient are having other things like hypertension. They also have cocktail personality, over-friendly personality, behaving like a drunk person. They are not drunk, but behave like that. Williams syndrome, right? And look at the fourth face. This is what you call as, look at the small head. Can you appreciate? Okay, I will be highlighting. Can you appreciate the small head? Microcephaly. Can you see this sloping forehead? Can you see the beak-like nose? And can you see the recession of the chin? Piche chala gaya hai. This type of face is what you call as bird-like facies or bird facies. So bird-like face or bird facies typically seen in patients with Seckel syndrome. So this is a child who's suffering from Seckel syndrome. And what is the gene involved in Seckel syndrome? They are characterized by ATR gene mutation. ATR gene mutation. And Seckel syndrome children always have short stature. They are also having severe short stature. So if examiner says bird-like facies, some immunodeficiency and short stature is present, what will you suspect? Seckel syndrome or ATR gene is the likely possibility, right? Yes, possibly we can expect that. See, marasmus or kwashiorkor surely aayega ki nahi aayega, we cannot predict, but we can only prepare according to what is likely asked in the exam, right? So Seckel syndrome. So 4 abnormal facies, we are done. Let us move further. We have a Kesher-Fleischer ring, which is brown ring at the periphery of the cornea. So there is deposits of a particular thing happening at the Descemet's membrane of cornea. They do not interfere with vision. So brown colored ring. Which deposits? Copper deposits. And this is a patient who's having a sunflower cataract. Can you see the yellow colored abnormal cataract? Sunflower cataract. Both of them are typically seen in which condition? They are seen in patients with Wilson's disease. Wilson's disease, also called as hepatolenticular degeneration. The other name is hepatolenticular degeneration. Autosomal recessive condition arises due to ATP7B gene mutation. Agar aapse puche which is the earliest organ to be involved, they present with hepatic involvement. What are the other organs which are involved in the second decade of life? You will have eye involvement as well as CNS involvement. And CNS involvement will be due to basal ganglia changes, copper deposits in basal ganglia. This tends to produce Parkinsonism, Parkinson's disease, along with hallucinations. So neuropsychiatric symptoms can be produced in the patient. And treatment obviously will be chelation agents, along with avoiding the diet rich in copper. So patient को क्या बोलोगे? Copper नहीं खाना. Do not eat copper. The patient बोलेगा मैं तो वैसे भी नहीं खाता. I don't eat it anyways. So you should avoid foods like chocolates. Chocolates are rich in copper. कल को आप ज्यादा chocolate खा रहे हो, कोई बोले why are you eating chocolate all the time? I'm having some copper, you know. So chocolates, nuts, liver, and meat, they should be avoided. Why am I writing? They are prominently mentioned, and they are a very old MCQ. Which foods are rich in copper? So avoid chocolates, nuts, liver, and meat. So fruit and nut chocolate, कौन सा patient नहीं खाएगा? Wilson disease patient will never eat. And along with that, you need to give chelation agents. Chelation agents in, for example, D-penicillamine should be given. Now you have better agents available like trientine and ammonium tetrathiomolybdate also. And zinc is sometimes given as an oral maintenance agent. It reduces the absorption of copper. Right? Tanishq Goyal PGI वालों की एक अलग ही अदा होती है. Tanishq, see, I personally believe yes, institute makes you, but at the same time, a lot depends upon other factors also. I have seen many people who are not, that grade coming from big central institutes. At the same time, I know a lot of my colleagues, my seniors, my juniors, who are from peripheral smaller colleges and who have done excellent in life, and they are doing excellent work right now. So yes, institutes do matter, and trust me, AIMS, PGI, JIPMER, and some state colleges like MAMC, UCMS, they have excellent working conditions and excellent skills you learn from them. But having said that, eventually it is the person who has to take use of whatever environment has been provided to you, right? Let's move further. आगे चलते हैं. Child less than 5 years of age having fever equal to or more than 5 days. Along with this, what is this? Thank you, Vicky. Thank you so much. I'm just trying to see from your perspective. Sometimes I talk about other things also, but I do it to only to avoid being too monotonous in the session, right? So strawberry tongue. Meet Patel, toxicity will always be there. And yes, mental health issues are a big problem for us. This is not the right forum to talk about it, but whatever has happened in the last few days, I think that is very sad. And there are people in power who should wake up, and there are people in power who, trust me, they have woken up, and it is being taken up in a serious manner. But change doesn't happen overnight, and change begins with us. Tomorrow, when you become a second year PG after doing first year, please do not be toxic to others. Remember how you were treated. Do not spread and continue toxicity. Break the chain. Someone has to break the change, and change always begins with one person. You cannot change system overnight. Toxicity has been there for many years. It will be there, but we can try to reduce toxicity at our level, right? And we all try to do it on our own ways. So make it a pledge that you will not be toxic to other people. You will be strict, but not go personal, right? So strawberry tongue. Yes, we heard about it. So let's stick to the discussion. Only 10-minute discussion is left. So let's finish it off. So strawberry tongue is there. Then the child is having bilateral non-purulent conjunctivitis. Bilateral non-purulent conjunctivitis. The patient is having peeling of skin, especially from the tips of fingers and toes. And the child is having a rash on the body. It is a polymorphous, but a non-vesicular rash. Vesicles are not present. And sometimes examiner will say also having unilateral cervical lymphadenopathy. If all these lesions are mentioned, the likely diagnosis in the patient is Kawasaki disease. Kawasaki disease, the drug of choice in these patients is IVIG, single dose. You can add aspirin also. If they ask, dono cheezein dete hain? Yes, dono dete hain, but drug of choice, king is only one. So IVIG single dose is given in these patients. It is also a past NEET PG as well as INICET question. Most common complication of Kawasaki disease is myocarditis. There are many textbooks and many sources which say coronary aneurysm. No, that is not true. Nelson में बहुत clearly लिखा है myocarditis. Myocarditis 70% cases में होता है, and it occurs in the first week of illness. Second most common complication and most common cause of death in Kawasaki disease is coronary artery aneurysm. Remember this funda. Coronary artery aneurysm. And can you see similar picture? Aneurysm. Oh, I'm a grammar Nazi. So sorry for that. Coronary artery aneurysm, right? And Kawasaki disease, similar findings can be seen in scarlet fever also. And scarlet fever is a streptococcal infection. They can have fever, strawberry tongue, conjunctivitis, rash on the body, peeling of skin. But scarlet fever, the fever responds to beta-lactam antibiotics. Here, the fever is unresponsive to antibiotics. So fever responds to beta-lactam, and that is scarlet fever in the patient. Kawasaki disease, yes, steroids are not given in initial cases, but refractory patients you can consider using them. Now, next scenario, there was an initial infection in a person, a child, it can be an adult also. A rash appeared 2 weeks later. Can you see this rash? So this rash is a petechiae as well as purpuric rash. This rash is appearing on the buttocks. It is appearing on the lower limbs. It is appearing on the pressure points. And all these lesions, they are palpable. And when you think of petechial rash, you always think of thrombocytopenia. There is no thrombocytopenia is found in these patients. So you have a rash which is present, There is abdominal colicky pain, so GIT involvement, arthritis, so joint involvement, cola-colored urine indicating hematuria, so renal involvement. So this is the classic tetrad of a condition known as HSP. What is HSP? Hanoch-Schönlein purpura. Hanoch-Schönlein purpura. Hanoch-Schönlein purpura, also called as IgA vasculitis. It is also called as IgA vasculitis. याद कर लो कि सबसे इंपॉर्टेंट परसेंटेज क्या है रैशेस का. सो 99% पेशेंट्स के अंदर होगा स्किन इन्वॉल्वमेंट, 80% patients will have GIT involvement, 75% patients have joint involvement, and 30 to 50% patients will have renal involvement. Percentages I'm writing because sequence of organ involvement in HSP is a old AIMS MCQ. तो ये percentages लिख दिया है. लेकिन अगर पूछें कि सीक्वेला क्या है, सीक्वेला मीन्स अ लॉन्ग टर्म कॉम्प्लिकेशन, वो होता है CKD और ESRD, एंड स्टेज रीनल डिजीज. सो relatively rare among the 4 presenting feature is renal, but the cause of death and the cause of long-term morbidity requiring sometimes transplantation is renal involvement in the patient, right? And what is the treatment that you will give? Treatment, what you will give? Conservative therapy, sub ke andar, conservative therapy. Why? Because most patients improve in 3 to 6 weeks. Most patients improve in 3 to 6 weeks. In case there is severe GIT involvement, like bleeding or severe refractory or abdominal colic, then you can give prednisolone or corticosteroids can be given. Otherwise, it is self-limited therapy which is given, right? Aditi Gupta trying to discuss neonatal resuscitation will mean another 30 minutes at least. So, okay, I'll give you one simple handmade flowchart so that you don't get it wrong. I'll try to come live again some other day before your NEET PG exam comes, right? Let's move further. Now, you have an infant presenting to you with vomiting. X-ray was done as shown below. What is the likely diagnosis? Look at the first image. In the first image, you can see that the child is having a single bubble appearance. Single bubble appearance. Here you can see 2 bubbles. So this is what you call as a double bubble appearance. And in this patient, you can see 3 bubbles. So this is what you call as a triple bubble appearance. So single bubble appearance typically seen in patients with CHPS, also called as IHPS, congenital hypertrophic pyloric stenosis or idiopathic hypertrophic pyloric stenosis. CHPS or IHPS. CHPS or IHPS patients, remember, they will have non-bilious vomiting, and that will be the clue. Non-bilious vomiting. Double bubble appearance will be seen in patients who are having duodenal atresia. It can occur in other conditions also, but if it is an infant, the likely cause is duodenal atresia. These children present with bilious vomiting, but there is no abdominal distension in the patient. Bilious vomiting without abdominal distension, right? And third condition, triple bubble appearance along with vomiting seen in jejunal atresia. Jejunal atresia. And jejunal atresia will have bilious vomiting with abdominal distension. बहुत छोटा सा point है. You have to look at the fine points, and these fine points make the difference. Do you know that people who get top 100 or 200 ranks in any competitive exam, they have almost similar level of preparation, similar level of understanding? The only difference which arises is only 1 or 2 questions. And if you look at the remaining people, it is only 5 or 7 questions difference between somebody getting top 100 rank versus somebody getting a rank of 1000 or 2000. And those 7 or 8 questions can easily be overcome by a clinical aspect. See, fact-based questions, you either know the fact or not. But when you get a case scenario, examiner will mention keywords. And when you are reading also, do not try to read like a robot. Try to read what is this person trying to say and look out for keywords. So if the MCQ says infant with non-bilious vomiting, CHPS, pyloric stenosis. If the question says bilious vomiting, no abdominal distension, double bubble, duodenal atresia. If the question says bilious vomiting, sub-abdominal distension is there, because now gas is getting collected. It is at least reaching till the upper jejunum, where atresia starts. So you will have bilious vomiting with abdominal distension. And treatment obviously is surgery. CHPS, you don't do direct surgery. First you correct the alkalosis and then you perform surgery, right? देखो रेडियोलॉजी का क्लास खलील सर का हो चुका है, तो रेडियोलॉजी आई विल नॉट गो इनटू द डिटेल्स. वी हैव टू फिनिश ऑफ द सेशन आल्सो. आपको जो भी डाउट्स हैं प्लीज, आई एम टेलिंग यू, यू कैन ऑलवेज मैसेज मी एंड स्टे इन टच विद मी. I will share my social media details. I will also share my personal number with you, but don't spam me. Like you can ask whatever doubts you have, but if you ask me कि सर मेरा लाइफ खराब चल रहा है, पर्सनल लाइफ में प्रॉब्लम है, पर्सनल लाइफ सबका ऐसा ही होता है. राइट नाउ लेट अस फोकस ऑन क्रैकिंग द एग्जाम, राइट? So, in case you have any doubts related to pediatric profession, most welcome to ask. Next question बोलेगा, there is a child having fever with stridor. Thank you, Dr. Vibhav. Thank you. So, fever with stridor, right? Fever के साथ stridor है, so some infectious condition. If the question says child is having barking cough, you will think of likely diagnosis as croup irritation, acute laryngotracheobronchitis. And in case patient is having a thumb-like projection like this, and the question says there is no cough, but the patient is having drooling of saliva, high fever along with drooling of saliva, the patient is also sitting and breathing in tripod position, sometimes also described as sniffing dog position, the likely diagnosis is acute epiglottitis. Acute epiglottitis. So this is how you make the diagnosis. And treatment. Medico is saying, I have texted you, you didn't reply. Medico, I sometimes miss. Where you send the message, please resend it or send on the other thing. I will reply to you, but I do sometimes. I'm bad in that. That I don't reply to messages has been, I have heard it from students. I have heard it prior to when I started teaching also. So I have suffered because of that. I know that, but try to send again, and if I will try to reply the best I can. So croup versus epiglottitis, treatment wise, causes and other things you have already read in ENT, so I will not repeat it, right? Let's go further. Now you have a 2-month-old child, central cyanosis is there, relief by knee chest position. Now 2 महीने के बच्चे में you cannot do squatting position, so relief of cyanosis by knee chest position or squatting position in a cyanotic heart disease, and the patient showing Cor and sabot. Cor and sabot. Cor and sabot is the French word indicating a boot-shaped heart. Boot-shaped heart. What is the likely diagnosis in the patient? Yes, the patient is suffering from tetralogy of Fallot. Tetralogy of Fallot. Top. Zamal, I will show you at the end of the class. I will show my Insta ID. Sandeep Sharma _108. Dr. Sandeep Sharma _108. If you type, you can search it. थोड़ा सा filter लगाया है, but इतना नहीं लगाया है. I will still look the same. So tetralogy of Fallot, this is the likely heart disease, right? And tetralogy of Fallot, remember, there is no shunt murmur despite there being a VSD in the patient. What you find instead is a pulmonary ejection systolic murmur in these patients. Pulmonary ejection systolic murmur is sometimes present, right? And if they ask you what is the palliative surgery done in the patient, the palliative surgery done is BT shunt, also called as modified Bilock-Taussig shunt, where we join subclavian artery to pulmonary artery. There are other types of shunts also described, but those shunts are not performed. The only palliative surgery done. But these days, corrective surgery or definite surgery is the ideal therapy to be done, and it should be done as early as possible. It should be done as early as possible. Medico, sir, my question is, if a child is less than 5 years, what is the drug of choice for absence of seizure? Medico, less than 5 years, there is no such thing as drug of choice. 2 drugs are considered first line, ethosuximide as well as valproate. And yes, many pediatricians are skeptic of using valproate in a young child because of chances of hepatotoxicity. So ethosuximide can be given. Having said that, more commonly used drug in clinical practice is valproate, because valproate has a more widespread type of action. If you read ethosuximide, they say that ethosuximide worsens some kind of seizure. So if there is a patient who's having vacant steering loop, but also has some other kind of seizure, you will be worsening the patient. And so if 2 types of MCQs can be asked, most effective drug for control of seizures, absence seizures, is ethosuximide. Most effective drug in atypical absence seizure, valproate. Commonly used drug for absence seizure, valproate, right? Examiner will not ask you to choose between them. Let's go further. 1-month-old child, central cyanosis is present. CCF is also seen. So there is a disease which has cyanosis in newborn with CCF, and chest X-ray is showing this. Similar image already asked in your NEET PG as well as INICET exam. This is what you call as snowman appearance, also called as figure of 8 appearance, also called as cottage loaf appearance. So snowman, figure of 8, cottage loaf appearance. What is the likely diagnosis? Supracardiac TAPVC. Supracardiac TAPVC. Supracardiac total anomalous pulmonary venous connection. You're welcome, Madhiko. And don't feel bad if I miss out on the message. Keep spamming, right? Spamming for the question, not otherwise. This is what I'm trying to say. So supracardiac TAPVC, right? And treatment is surgery. Now, supracardiac, now many types of TAPVCs are there, which supracardiac TAPVC, 2 points you need to remember. All four chambers, right, left atrium as well as ventricle, all 4 chambers have similar or same SpO2. MCQ one-liner question asked in INICET exam. Name the congenital heart disease where all 4 chambers due to mixing of blood happens. So this is TAPVC. Second, there is a variety called as obstructive TAPVC. Obstructive TAPVC, also called as infracardiac TAPVC, which does not respond to medical management and has a high mortality. And so urgent surgery should be done in the first week of life. There are many types of TAPVC. Supracardiac TAPVC, you can do surgery later, some weeks later. But name the type of TAPVC where urgent surgery needs to be done: obstructive TAPVC or infracardiac TAPVC. Yes, Ribab is right. It is the most lethal type of TAPVC, right? It has more than 90% mortality if you don't do surgery in the first week of life, right? Let's move further. 2-year-old child, fatigue. Now, cyanosis is not there. Fatigue on exertion, pain in calf muscles on running. So something compromising the blood supply to lower limb. Hypertension is present. Usually hypertension is more in the upper limb compared to lower limb, but in general, some children present with overall hypertension. Chest X-ray is showing here. Chest X-ray is showing this sign. Can you see this and then this? And there is a notch being produced here. This is what you call as 3 sign, also called as reverse E sign. So 3 sign or reverse E sign is seen in patients of coarctation of aorta. These are the patients who have radiofemoral delay and coarctation of aorta. Most common type is juxtaductal variety. So juxtaductal in front of ductus arteriosus, narrowing is maximum. So that is the most common type of coarctation of aorta. And treatment obviously is surgery. Remember that inferior rib notching can occur in coarctation, but it appears after 10 years of age. So remember, inferior rib notching aajkal kam dikhta hai, which occurs due to collateral development, appears at or beyond 10 years of age. Most of the coarctation these days, they are diagnosed before 10 years and you do surgery. So now inferior rib notching is not commonly seen in these patients. Now, 3 neural tube defects we are going to discuss here. This is a similar image which was asked in FMGE exam. So all my students who are NEET PG and INICET aspirant, FMGE के examiner भी same होते हैं. So this can spill over. And for FMGE aspirants, this is a past recent image. So look at this first neural tube defect. Can you see that this child is having absence brain formation? This is what you call as anencephaly. Anencephaly, right? And secondly, can you see there is a splitting of the vertebral column like this, exposed to the outside? This is called as rashesis of the vertebral column. Together, अगर ये दोनों किसी बच्चे में हो, it is a rare but lethal neural tube defect called as craniorascesis. Craniorascesis. It's a combination of 2 things which is being shown here. अगर ये photo B वाला photo ना होता, if B photo was not there, the right photo was not there, the answer would have been simple anencephaly. But because both are mentioned, the diagnosis here is craniorascesis. Stillborn, not compatible with life. Second neural tube defect. Child is asymptomatic. Asymptomatic child. No swelling is seen, but in the back, in the L5S1 region, you will find a tuft of hair like this. So any skin marker in lumbosacral region in asymptomatic child, which neural tube defect will you suspect? Spina bifida occulta. Occulta means hidden, chupa hua, daba hua. Also called as occult spinal dysraphism. Occult means hidden. Some people do hidden practice, hidden preparation. They tell to others, I am not preparing for the exam. but they prepare very hard. And these are the people, you must have seen some of your seniors. They would never read, but they would crack the exam with a very good rank, or they would get a very good score in FMG paper, or in INICET, they top 500 rank they will get. These are the people who have different faces, two-faced people. बाहर दिखाते हैं that we are enjoying life, but when they reach back their hostel or their room or their library, they work hard like anything. So it doesn't matter how many hours you put in. What matters is how consistent you are, how focused you are, and how many quick revisions that you do. People who say you need to read 16 hours in a day to get selected, nonsense, rubbish. People who say you can get selected with 1 hour reading every day, absolute rubbish. Usually, most people who get top ranks read between 6 to 8 hours in a day. So as exams come, last month, they increase it up to 12 hours. But consistency and number of revisions, balance between subjects, and equal weightage to theory and MCQs, and not looking for quick fix solution. Too much, there is no substitute for reading your own handwritten notes, going for a miracle program or miracle session. Like I will be holding some sessions, but if you think only listening to my session, you will get all the MCQs in pediatrics correct, that is not going to happen. You need to read whatever notes that you have made, right? So simple things, but do them consistently. So this is spina bifida occulta, right? This is the most common type. This is the most common type of neural tube defect. Most common type of neural tube defect. And there is a patient who's having this. This is a child having a globular swelling. And globular swelling, sometimes it will rupture, sometimes it will not rupture. This is what you call as meningocele or meningomyelocele. You can distinguish between what is meningocele? Only CSF is there. Meningomyelocele, spinal nerves are also herniating. What is the difference between them? In meningomyelocele, because spinal nerves are herniating, so patient will have paraplegia also. So paraplegia is often present. Meningocele, paraplegia is usually rare, but both of them require repair. Both of them require neurosurgical management, right? Ribam Gupta, which craniosynostosis syndromes are important for NEET PG? I think you joined late. I have already said Apert syndrome and Cruzen syndrome are very important. Others, you read them, no problem with that. But if you miss them, still, there should not be any problem. And for INICET, there is a list of syndromes. I've discussed in my DocTutorials lecture also. So, list of syndromes where craniosynostosis is seen, because there is a past AIMS question. All of the following are syndromes associated with craniosynostosis except. So, उसमें list है, at least 5-6 syndromes are there. Those you should at least know. So these are the types of neural tube defect. Neural tube defect, remember, prevention is better than cure. Maternal folate supplementation is always needed. And what is the dose of folate supplementation? Folic acid supplementation is 0.4 mg per day in all pregnant females, and it is 4 milligram per day in case of baby with previous neural tube defect, right? 0.4 mg per day will be 400 microgram, and 4 mg per day will be 4,000 microgram. So kabhi they can put the option in microgram as well, right? So neural tube defect is done. Look at this child. This child is having a large head, so macrocephaly. And you can see in the eyes of this child, she's having a sunset sign, also called as setting sun sign. Part of sclera above the eyeball is unduly visible. So they are both suggestive of which condition? Hydrocephalus. Hydrocephalus is increased CSF causing large head in the patient. Hydrocephalus, remember 2 points. There is no papilledema. What is papilledema? It's a past NEET PG question. Papilledema is swelling of the optic disc because high pressure is dissipated by the increased head size, so papilledema never occurs. And AIMS MCQ, what is the surgical procedure of choice? The surgery of choice in these patients is VP shunt. We call it as ventriculoperitoneal shunt. Yes, Shubhang Lalit Kumar, absolutely right. Anencephaly can be earliest not 11 to 13 weeks. It can be diagnosed around 10 weeks also, right? But again, yes, if you have to choose one, then 11 to 13 weeks. The question which you are talking about, it did not have an option of 10 weeks. So we marked 11 to 13 weeks. That was the best answer. Next question, similar image asked in NEET PG exam. There is a child who's having closed fist and there is a crossing hypertonia of the lower limb leading to seizuring of the lower limb. What is the child suffering from? He's suffering from a condition known as spastic diplegic type of cerebral palsy. Spasticity hai. Stiffness is there. So spastic diplegic type of cerebral palsy. It's a spotter question asked in a NEET PG exam. And what is the cause of spastic diplegic cerebral palsy? It occurs due to damage to periventricular white matter called as periventricular leukomalacia. Periventricular leukomalacia is damage to white matter which occurs in preterm newborns due to asphyxia. That as during childbirth, if there is delayed cry, there will be damage to white matter around the ventricle. Later, the child will develop spastic diplegic cerebral palsy, right? So types of cerebral palsies होते हैं. There is a quadriplegic, there is extrapyramidal. तो जो quadriplegic होती है variety, that is the most severe form. This is the variety which has multiple associated mental retardation and other things. And we have extrapyramidal, also called as dyskinetic or choriothetoid cerebral palsy, which is associated with kernicterus. So ये आपके दो additional pearl one-liners हैं. You should remember for the exam. So I do not need to repeat it now, that you should save this video and watch it again on 2x close to the exam, and whenever you get time traveling somewhere, when you're revising your pediatrics from your existing notes, right? So trust your notes and just do them multiple times. Look at this image. Panel of images, what you can see. Can you see a single transverse palmar crease in the hand of the child? Yes, this is what you call as a simian crease. Look at this finger. This is a short curved finger, what you call as clinodactyly. Clinodactyly. And thirdly, can you see the gap between the first and second toe? That is what you call as sandal gap in the patient. So if there is simian crease with clinodactyly with sandal gap, what is the likely diagnosis? Tell me. What is the likely diagnosis? Yes, you know it. ये तो आसान है. Down syndrome. Most of you have answered it already. Down syndrome, trisomy 21. Do you know there are people who are very well prepared, but they mark Down syndrome wrong in the exam? Yes. There are some people like that. One of them is a very close friend of mine, and right now a leading surgeon in Delhi, right? Not into teaching, of course. He's into the surgical aspects, and he still says, he still reviews the fact that I could have got, मेरा 2 seat से मेरा dream college का seat miss हो गया because I marked Down syndrome wrong in the question. So shit does happen, right? Mistakes do happen. They happen with everyone. The point is to minimize them as much as possible, and more practice of MCQs will ensure that you don't do them. Down syndrome, huge number of one-liners, about 20-25 one-liners are there. Please read them from whatever sources. There we are doing the image-based discussion. Now, look at a past MCQ. Past MCQ, newborn was found to have microcephaly, cleft palate, rocker bottom feet, and sluggish reflexes. What is the likely diagnosis? Option had both Edwards syndrome and Patau syndrome. Many people marked Edwards syndrome because of rocker bottom feet, and many people marked Patau syndrome because of cleft palate. What is your likely diagnosis? Yes, the likely diagnosis is Patau syndrome. Because rocker bottom feet is described in Edward, but can occur sometimes in Patau also. So Patau syndrome or trisomy 18. Trisomy 13 is the reason for in the patient. This is the mistake we all make. Rocker bottom feet देखा तो सीधा tick कर दिया Edward syndrome. I know that there is a reason I put this question. There is a reason. Some of you have answered it wrong. I knew it. See, when we are students, ये rookie mistakes होते हैं. मैंने भी किया अपने time, right? Now you will not make the mistake now. At least this is the takeaway from this session. So remember, if you have an image, a question is saying a syndrome in the patient, you have overlapping digits. Along with 80% patients are found to have rocker bottom feet. Along with other things. What will you suspect? Edwards syndrome. Baki cheezein I'm not writing, you know the features, right? And if in case you have cleft palate, cleft lip and cleft palate, along with 20% patients, up to 20% patients can have rocker bottom feet. And when you do MRI of the child, you will find a neuronal migration defect called as holoprosencephaly. Detail will not ask. Remember this word. So these will be clues that the patient is suffering from Patau syndrome. And Edwards syndrome is trisomy 18. Patau syndrome is trisomy 13. Baki cheezein aap padho. My purpose here is to discuss the image, highlight the key point, and also highlight the point which you make mistakes. And that is why it's the polishing, thing we are doing here. Core thing is to be done by you. Now, male child, similar image, similar case, already asked in past NEET PG exam. Male child, bleeding episodes, recurrent infections and rash as shown. This is the rash which is similar to the rash seen in atopic dermatitis. So atopic dermatitis like rash, also called as eczema, occurs in the flexural aspects. Aditya Pathak is saying rocker bottom. See, हमारा foot का arches होते हैं, there is concavity which is there, right? When that concavity becomes convex like this, that is called as rocker bottom foot. तो जैसे ये foot है ना? ऐसा एक concavity होता है foot में. This is the normal foot. If the foot becomes like this, that is called as rocker bottom feet. This is a very crude depiction I'm saying, but technical things you can always Google and you can see from the orthopedic notes. No, Sana, club foot is not. See, club foot is CTEV. Rocker bottom feet can occur in club foot as a complication of the surgery or complication of correction. So please remember, club foot and rocker bottom foot are not same. Again, a rookie mistake we all make. So male child, yes, the male child, bleeding episodes, recurrent infection, atopic dermatitis or eczema. This is the classic triad of a syndrome known as Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome. Dr. Zamal, Ehlers-Danlos syndrome. यार मेरा भाई बोले तुम लोग. Ehlers-Danlos syndrome is a syndrome in which there are multiple things which happen. There is a gene called as JAGD1 gene abnormality, and patient develops newborn cholestasis. So hyperbilirubinemia will be there. There will be butterfly-shaped vertebra, and the patient will have ocular changes. That is called as Ehlers-Danlos syndrome. All right. So Wiskott-Aldrich syndrome gene is WASP gene. Similar case discussion has also case scenario already asked in INICET also. X-linked recessive, so seen only in boys. And what is the classic triad of Wiskott-Aldrich syndrome? They have a eczematous rash. They have bleeding manifestations. Why bleeding manifestations? Because the platelet count is low, as well as the number of the size. Number as well as size, both of them are found to be reduced in the patient. And thirdly, they have recurrent infections because of abnormalities in both T cell, as well as altered immunoglobulin profile. For example, these patients have low IgM and elevated IgG. Right? This is the Wiskott-Aldrich syndrome. Yes, Varnik, peripheral pulmonary stenosis is the most common congenital heart disease in Ehlers-Danlos syndrome. Right? And so we have come to the end of the session. For those who were asking, sir, what is your Instagram, email में सबसे कम खोलता हूँ, but if I have to share something, you ask me for something and I have to share, you can go there. Telegram, अभी सुस्त पड़ा है because I did not have time to handle it. I will be activating it soon. And clinical updates, if you want to see only reels where I'm doing stupid things related to entrance exam, but nothing personal stuff, that will be on clinical essentials _ Dr. Sandeep. So this is Insta and this is also Insta. Ideally, you should follow both. If you can't follow one, you can follow one of them, right? And for those who asked what is Ehlers-Danlos syndrome, Ehlers-Danlos syndrome occurs because of JAGD. It occurs because of mutations in the JAGD1 gene or Notch2 gene mutations. ये दो genes होते हैं. Either of the two gene mutations can produce it. Key features you will watch out for. They have neonatal cholestasis. So cholestasis will cause conjugated type of jaundice in the newborn period. They will have butterfly vertebra. They will have a congenital heart disease. Which congenital heart disease? As very rightly said, peripheral pulmonary stenosis, peripheral PS, and they will also have ocular abnormalities in the form of posterior part of the eye showing abnormalities like posterior embryotoxon. अब ये क्या होता है, ये मैम आएंगे ophthalmology session में, Dr. Shivani, so you can ask ma'am, right? Referred to ophthalmology. I'm not going to take it up. Ophthalmology वैसे भी मेरा weak है. So this is Ehlers-Danlos syndrome for those who ask the details about it, right? And most of your other queries I've already answered. Someone asked about neonatal resuscitation. Remember, whenever there is a child who does not cry immediately at birth, remember in newborn resuscitation, it will require a separate discussion, obviously. Neonatal resuscitation may always remember, first you assess the child as soon as birth happens. In case the child needs to be examined and resuscitation needs to proceed, you perform the initial steps. What are initial steps? Providing warmth, dry stimulation of the child, positioning the airway, as well as suction. Suction first mouth, followed by nose. And then if the heart rate is less than 100, or there is poor respiratory effort like apnea, or patient is having gasping efforts, you start with positive pressure ventilation, which is majorly given by bag and mask ventilation. And in case patient has heart rate dipping below 60 despite PPV, you will do ventilation corrective steps also in between. I'm skipping over those. Then you will intubate the patient, give PPV via endotracheal tube. You will do chest compression. You will coordinate them. And you will give 100% oxygen at this step. This is a common mistake people make. शुरू में 100% नहीं देते, यहाँ पर देंगे. And still not improving, you will give IV epinephrine. Epinephrine is also called as adrenaline every 3 to 5 minutes. And you will rule out the reversible causes. बीच के कुछ स्टेप मैंने स्किप किए हैं for the simple reason कि वो आप पढ़ेंगे डिटेल में, but they are not asked that frequently in the exam. So if you get a case in the exam, or a one-liner or a case scenario, this should be good enough to go, right? This is the summary of what I need to remember. Oh, thank you, Aditya. I'm also tired. I also need to have some food. I'll have it. I'm at home now. So, notch to Aditi Gupta. Let me discuss with the DocTutorial team if I can. Aditi, before 20th January, if you are asking about FMG, I'm going to conduct a session, 3-hour session for FMG students on Dr. G. Bhanu Prakash's channel. So 3-hour session. 14th December, I am coming. Evening 6 to 9 p.m. So you can join me there. Thank you so much. Got 146 in prep ladder all India grand test. If you have got 146 in a grand test, you are almost there. Analyze the paper. Find the mistake. Are you skipping any high yielding topic? Are you skipping any subject? Are you doing enough practice? Do you have 100% accuracy in previous year question? Are you solving grand test every 10 to 15 days or not? ये 5 में से problem होगा. Work on that problem. Give another grand test after 10 to 15 days and you will see your score picking up. Try this. 1 out of these 5 you need to analyze. Thank you so much. Thank you so much. See, some of the grand tests of one institute will always be tougher. One institute will be easier. Nobody knows how the exam is going to be. The purpose of grand test is to help you in time management and to give practice to your brain to solve the MCQs, right? Aditi Gupta, 2% rule for CPR. This is not CPR. This is neonatal resuscitation. We call it as NRP program. Newborn resuscitation is different from CPR. CPR होता है cardiopulmonary resuscitation. उसमें होता है sequence, compression, airway, breathing. यहाँ पर देखो ventilation यानी कि breathing सबसे important है. So NRP is totally different. Newborn is totally different from older children. So CPR के अंदर 1 rescuer, 2 rescuer वाला फंडा चलता है. यहाँ पर no person can do resuscitation alone. You always do it as a team. So 2 people are always required. Ideally 3 people. One of the nursing staff should also be there. Thank you, Aditya. Shreyansh Dahiya, I will talk to DocTutorial team, but I cannot promise that because this is a management decision, not mine. So I don't know whether they'll be giving PDF and other sessions they have given PDF or not. But this session will be available to you on YouTube. You can watch it again. And I think that would be more beneficial. Ajit Chaparna, we are waiting for... Yes, Ajit, rapid revision, FMG rapid revision. Specific FMG rapid revision. 14th December, I'm coming live, 6 to 9 p.m. The DocTutorial channel, Dr. G. Bhanu Prakash channel in collaboration with DocTutorial. Apart from that, for NEET PG and INICET aspirants, separate small session I will be planning in discussion with DocTutorial soon. So that days I will announce later. Right? Rajesh Kumar ABG basic video. It's on my to-do list. If I could show you, it is on my to-do list. ABG, reading ECG basics, that is there. But as soon as I get time, I will do that. Rebab Gupta, ECG of medicine. You should be asking the medicine faculty for that. But yes, a few things when I take the ECG discussion, when I take it, so I will be covering the how pediatric thing differs from the adult part also. So I will take that, so you will have some clarity at that time. Trinath Mishra, okay, point taken. Okay, thank you so much. Now the session has gone too long. There are people also looking at me. at DocTutorials who have to go back to their homes also. So thank you so much for getting connected with me. You can ask me any doubts. I take some time to reply, but I will try that I reply to your messages. And as I said, 9855554241. आप इसके ऊपर ओनली व्हाट्सएप कर सकते हैं, इसके ऊपर कॉलिंग नहीं चलता है, राइट? एंड आई ओपन इट, दिस इज ऑब्वियसली नॉट माय प्राइमरी नंबर, सो यू कैन post your queries on WhatsApp if you have here. So I will try to answer as much as possible. But ये कभी-कभी on होता है, नहीं तो मैं सारा दिन फोन बजता रहेगा. So Insta is the place where you can find me more often. So try to connect and message me. Right? Thank you so much. Seen you after a while when you came to my college nostalgia. Thank you, Aditi. Which college you are? I think you must be from some, I think Kyrgyzstan or Tajikistan, because those are the places I had gone. So nice to meet all of you. Thank you so much. Bye-bye. Good night. Keep working hard and let the exam that you sit in be the exam that you sit in, and you don't need to repeat that exam for any XYZ reason, right? Ho jayega. And once you get selected, I will be happy, very happy. You drop me a message, sir, I got the rank. Not for any, credit, anything. No, it's your credit. You might be reading and preparing from other teachers. But I feel happy that I have interacted with someone and someone says, ki, sir, mera ho gaya. So it's like, personal satisfaction you get. It's always nice to hear that. So do stay connected and watch out for the upcoming sessions at DocTutorials. Other teachers, other excellent faculties, legends in their field are also going to come and take your session. So bye-bye, good night, do take care, and we meet again. Whatever pending more doubts are there, we can always talk later. Thank you so much.